community through the Humanitarian Program Cycle Steering Group. Over.
Thanks. Next, Brioni.
Thank you, Antonio. Bryony Stevens. I am on the GNC CT supporting the coordination help desk. Thank you, and over.
Masumi.
Hello, everyone. My name is Masumi Yamashina. I'm working with global nutrition clusters and other clusters for GBB risk mitigation.
Thanks, Masumi. Ahmed, please.
Hi, everyone. Ahmed Ghanem. I'm a program specialist at UNICEF, specifically in disability inclusion in HNO HRP.
Thank you, Ahmed. Victoria, please.
Hi, colleagues. My name is Victoria Silvaplan. I'm the GNC NIS Help Desk. I'm sure I've already been in touch with a number of you, and I look forward to further our discussion today. Over.
Thanks. Angeline?
Hi everyone, my name's Angeline Grant. I'm the GNC Coordination Help Desk for Francophone countries, and I also work on capacity development for the GNC.
Thank you so much, Angeline. Thank you, colleagues. I would like to thank OCHA for joining this webinar, and also they did join the HNO webinar, which we had back in July, and their collaboration has been very helpful in the HPC process. I think I forgot to mention my name. My name is Antena. I lead the GNC country support team at the Global Nutrition Cluster. Today, we will be covering 4 main sessions. The first one will be specifically focusing on the overview of the HRP process. That would be covered by Uta, and followed by the presentation from Brioni, focusing on the HRP process from the nutrition lens. And after that, we'll be talking about the key considerations in the HRP process. This is specifically looking at the GBV, gender, disability, AAP considerations, important cross-cutting considerations. And followed by this, I will be talking briefly about our roles and responsibilities in the HRP process. And also, I will talk briefly about what support GNC coordination team will be providing to the countries. So as you know, the HRP is an important document, an important process in the humanitarian programming cycle. And it is an important document that serves as a guide for guiding the response in countries in emergency. It is also an important advocacy document for resource mobilization. Therefore, we need to really spend a good deal amount of time, and we need to do it in a very consultative way so that it is credible and realistic and needs-based. And to ensure that there are important considerations which we need to take, that will be discussed in today's webinar. And also we would like to, by the end of this session, to clarify how you can be supported during the HRP process. At the end of each subsection in today's webinar, we will have a Q&A session. I would like to ask you to post your questions at the chat box. Angeline will be monitoring the questions, and we will respond after each session. And we will also have Q&A towards the end of the webinar. We'll probably spend between 10 to 15 minutes for Q&A. So with that, I would like to hand it over to Uta to take us through the overview of the HRP process. Thanks. Over to you, Uta.
Thank you. So we can go to the next slide. So there have been a number of updates to the 2021 HPC, and why is that? Those of you who were already engaged in this cycle
are aware that we embarked on the enhanced HPC process in 2019 for the HRP and HNO 2020. To recap, the elements applied include a focus on the multi-sectoral nature of needs and the response, understanding of the causes, the level of severity, and likely evolution to allow for a more effective response with linkages to development interventions, a focus on identifying priority groups and geographic areas directly based on the needs analysis, and formulating results-based strategic objectives, which define the changes we want to see in the lives of people, and ensuring inclusivity through disaggregation and analysis of the differential impacts of a given crisis and the associated needs for diverse groups of people, such as, for example, gender, age, disability, and other diversity characteristics. There were a number of reviews of the HPC 2020 process, including 2 interagency reviews. One is the multi-partner review, and the other one is the HPC 2020 quality scoring of humanitarian needs overviews and humanitarian response plans. The results of the reviews were used by the HPC steering group to inform modest changes or adjustments to the next HPC cycle. So for 2021, as you can see on this slide, the focus remains on linking the needs analysis to the response analysis. The basis of the humanitarian response plan is, as you know, the HNO and the joint intersectoral analysis framework. On accountability to affected populations, on linkages between humanitarian and development plans, and protection will be mainstreamed. And as you will know that the GHRP is coming to an end of December 2020. COVID-19 will be considered as part of the overall needs in the HNO and respond in the HRP. Over. And next slide, please. So how do we get from the HNO to the HRP? As discussed during the HNO webinar, the 2021 HPC has an increased emphasis on an improved evidence base, primarily by ensuring that the HRP is underpinned by the HNO. This refers to both the intersectoral sections as well as the sector plans for the HRP. By ensuring clear linkages between the evidence in the HNO and the response in the HRP, the credibility of the HRP will be enhanced. Next slide, please. So this webinar on the development of HRPs follows on from the earlier webinar you've had on the development of HNOs, which discussed steps 1 to 4 of the 2020 HPC process. As for the HNOs, the development of HRPs consists of 4 steps, which corresponds to step 5 to 8 of the HPC process, and these are captured in the step-by-step guide. So let's go through the HRP steps 5 to 8 from the SBS guide. So step 5, to recap, the starting point for the response analysis is the HNO, which captures severity, magnitude, causes and consequences of needs, people's own priorities, as well as trends and projections. This is used to formulate an initial set of intersectoral strategic objectives for the HRP, which articulate the intended improvements in people's lives over the HRP period, and an initial set of intersectoral and sectoral specific objectives. Each specific objective should contribute to the achievement of the respective strategic objective. The next step, step 6, is the response analysis, and I'm going to spend a little more time on that. So what is response analysis? So in the complementary guidance which was developed, we defined response analysis as a joint intersectoral process which facilitates the identification of appropriate, relevant, and feasible interventions and modalities to respond to the humanitarian needs identified in the HNO. So response analysis consists of formally reviewing the range of possible interventions to address identified needs in order to select those interventions which will meet the identified needs in the most effective and efficient way. The response analysis results in the identification of the population and subpopulation groups and locations which will be targeted in the HRP. So let's have a little bit of a closer look into the criteria: appropriateness, relevance, and feasibility. So what is an appropriate intervention? Appropriate interventions are those which are most likely to meet the needs. So these interventions reduce needs or increase resilience of people, or both. Appropriate interventions are those which do not duplicate plans by other actors, such as, for example, by the government or by the Red Cross and Red Crescent movement. And appropriate interventions are those which are complementary to other plans, such as development plans. As you will recall, this is something we showed in the earlier slide as a priority for 2021. The second element for the response analysis, what are relevant interventions? So relevance refers to interventions which address population's own priorities and preferences. So a possible intervention might be appropriate to reduce needs of an identified population group, for example, a cash for work intervention, but it might be irrelevant for this part of the population if, for example, people are afraid to leave the house for various reasons, such as, for example, lack of identity documents or permits. An intervention might be both. It might be both relevant and appropriate for the subject population group, such as, for example, if there's a health intervention which addresses medical needs of the identified population group, and the services are provided in a way which the community prefers, for example, through a mobile health clinic, if there is a need or a preference that the service is delivered close to the community. So it's relevant for the population concerned. The third element of the response analysis is feasibility, and I'm sure we can all name a lot of feasibility constraints. Various access impediments, operational capacity. So is there actually an organization who can implement, are there functioning markets, are there healthcare services or other government services? In terms of priorities, there might be a need to prioritize in the sense that efforts to resolve feasibility constraints focus on the people with the most severe needs and to sequence responses so that time-critical interventions come first. So as a result of the appropriateness, relevance, and feasibility review, there will be a clear understanding of what interventions can be delivered and how within the time frame of the HRP. And from there, we can go to finalize the formulation of strategic and specific objectives and target estimates, which is step 7 in the process. So once the appropriate, relevant, and feasible intervention or interventions are defined for every specific objective, the wording and the figures have to be adjusted because the selected interventions might not permit to reach all of the originally intended target groups or locations given the analysis of feasibility concerns, for example. As we said before, the strategic objective is the sum of the specific objectives. Also, these might have to be adjusted to reflect what the combination of specific objectives is realistically able to achieve. The next step is the formulation of projects and the costing of the HRP. Next slide. So we are keen to hear from you what steps of the HPC are you currently at? And I'm handing over to Briony. So there is a global level timeline for the HNO and HRP process, but these timelines vary significantly between countries. For example, we know that Myanmar have now completed their HNOs, while other countries, for example, Zimbabwe, are working on the PIN. So we're waiting to see the results of the poll. In general, step 5 occurs August, September, step 6, September, October, step 7 in October. And this is then followed by the project formulation and costing in November. And for us as OCHA headquarter, the hard deadline is the 9th of November, where we receive through the OCHA country offices the input for the global humanitarian overview, which will be launched on the 1st December. So as we can see from the poll, 1/3 of the votes are in. So scope of the analysis and costing approach agreed upon. Defining scope of HRP and formulation of strategic objectives was done by about 1/4. And in a few countries, the strategic and specific objectives and indicators are finalized and prioritized. So basically, this confirms what we what we were expecting. For me personally, it would be interesting to see step 6, like 0% conducted a response analysis, but then 13% are stating that the strategic and specific objectives and indicators are finalized. So it might be interesting to look a little bit into how that occurred, because as we just discussed, the response analysis should finalize the strategic and specific objectives. So it should come before that. Shall we move on from here to the next slide?
Sorry, Uta, I've just moved on to the next slide. Are you able to see it?
Yes, but I'm still seeing like the poll and on top of it.
Apologies. Okay, I'll try to do that. Thank you.
So I somehow it's still there, but I think I can see most of it. So
You can just exit the poll. So colleagues, if you haven't, you could also X out the poll if it's still on your screen.
So as discussed earlier, the HRP builds on the HNO, which provides the evidence base and analysis of the magnitude of the crisis and identifies the most pressing humanitarian needs. So these needs inform strategic objectives in the HRP as a result of the response analysis, and the cluster plans follow from these strategic objectives. So while the HRPs are primarily recognized as management tools, as was said earlier, they also act as a resource mobilization tool. In terms of the structure of this year's HRPs, there's good news. As I said earlier on, there are no significant changes in this year's HRP template compared to last year. So for those that participated in this process, the HRP template and process will be somewhat familiar. The document consists of an executive summary and 5 parts. As I said earlier on, we had a number of reviews and which informed the small adjustments of the document. For example, there's now more emphasis on response analysis and what we hope clearer guidance on what should be documented on monitoring. So while the cluster and sector plans are listed under part 3, it is important to highlight that the other sections are intersectoral, and the inputs of the nutrition cluster sector are required to ensure that nutrition is adequately addressed in the intersectoral parts of the document. So, and how to do this exactly will be discussed by GNC colleagues over the next set of slides. Thank you.
Thank you so much, Uta. So if there are any questions for Uta, please feel most welcome to share those questions now.
I think if there are no questions, Brion, you may proceed, and we'll continue to monitor the questions on the chat box. Thanks.
My apologies, there's just a slight glitch with the PowerPoint. Just 1 minute. Okay, I'm sorry, the screen has just frozen. I'm just going to take it off the share and launch the PowerPoint. Thank you. Okay, so I do apologize to all colleagues for the slight glitch there. We did anticipate a few issues with the PowerPoint because it does appear to be quite a large file size, so I do apologize about that. So many thanks, Uta, for the overview of the HPC process, and good afternoon, everyone. We will now discuss the HRP process through a nutrition lens. And it seems to have frozen again. There we go. Okay. So this table illustrates steps 5 to 7 of the HPC cycle. The main outputs for each step, the actions required by the nutrition coordination team at an intra-cluster level, and also the actions required at an inter-cluster level. So as discussed by Uta, the first stage of the response analysis, which corresponds to step 5 of the HPC process, takes the outputs of the HNO needs analysis to determine the scope of the HRP. These outputs are then reviewed at an intersectoral and cluster or sector coordination level, considering factors such as the emergency severity, the magnitude, trends, projections, underlying causes, and people's own prioritization of their needs to identify priorities against the need. This analysis results in the formulation of the initial set of the intersectoral strategic objectives, as well as the initial target populations and locations for the HRP. So this ultimately defines the HRP. So ideally, the cluster or sector, so I do use these two terms interchangeably, but I do recognize that it depends on the country context. So the cluster or the sector coordination teams are to contribute to these discussions by sharing the cluster priorities at the intersectoral coordination level for consideration. To inform these discussions, cluster coordination teams are recommended to jointly develop a list of prioritization criteria based on the outputs of the HNO and develop a prioritization matrix by region and or a matrix or even potentially heat maps, which then can be used to guide the discussions. So the second stage of the response analysis is to formulate an initial set of intersectoral and sectoral specific objectives for each of the draft strategic objectives. So these strategic objectives are to be complementary and contribute to the achievement of the strategic objectives. While this activity is at an intersectoral level, cluster teams can prepare for these meetings by brainstorming possible responses and to bring a short list of interventions back to the inter-cluster coordination level, as well as back to the cluster and or sector level to identify complementarities and synergies and finalize the intersectoral and sectoral specific objectives. The third stage of the response analysis is to review the appropriateness. So this is defined as interventions that will most likely meet the humanitarian needs. So for example, this can include OTPs or SAM without complications. And then also the relevance. So this is defined as population's own priority needs and preferences from, for example, mobile IYCF clinics, and also feasibility. So this is defined as operational factors, for example, physical access to BSFP distribution points during rainy season. So of different interventions and intervention modalities, and define who should be targeted with what, where, and for each specific objective. The response analysis is conducted at both an intersectoral level to identify the intersectoral response synergies and at a sector level to analyze sectoral interventions, usually through a workshop approach, but it does depend on the country. The results of these reviews is a refinement of the population and geographic targets for each of the different types of interventions. So then the fourth stage of the response analysis is really to agree at an intersectoral level on the articulation of the various responses based on the results from the response analysis, and to finalize the strategic intersectoral and sectoral specific objectives, including a quantification of the number of people targeted. So this intersectoral level discussion is also key to consider integration. So for example, or intersectoral collaboration, for example, WASH and nutrition assistance in healthcare centers, sequence, for example, OTP for a SAM child, followed by agricultural assistance, or layered responses, for example, food and agricultural interventions, target the same geographical area. So this is usually done in a workshop setting or through a task force. And this step also includes the development of the cluster and sectoral response plans, also the identification of cluster objectives and a quantification of the number of people to be targeted. So we'll discuss that in a little bit more detail in the next set of slides in terms of the cluster and sector plans. At an intersector sectoral level, once the objectives are defined and finalized, the indicators to monitor the strategic and specific objectives are identified. The purpose of these indicators is to enable progress towards each of the strategic objectives in terms of how they will be monitored. And these indicators are at an outcome level and therefore discussed at an intersectoral level. So just to flag, when we speak of prioritization, prioritization occurs throughout each step and specifically refers to focusing efforts to ensure that those most affected are targeted. Also the sequencing of responses so that time-critical interventions take place first. And lastly, ensuring that interventions are part of a package and not standalone, and ensuring complementarity of efforts across the response. While the development of the HRPs may come across as process heavy, there is a lot of guidance to support you both with the intersectoral sections of the HRP as well as the nutrition cluster or sector plans. So as mentioned by Uta, specific to the HRP process, OCHA has developed complementary guidance on response analysis and prioritization, and has also revised the step-by-step guide and HRP templates. So these documents can provide you with detailed information on each step of the HRP process. That said, these documents do lack guidance on the development of the cluster and sectoral response plans. However, this shouldn't be an issue as the GNC has a plethora of guidance to support you with the cluster and sector plans. One existing tool is the Nutrition Cluster Coordinator Checklist. This resource provides guidance on both the intersectoral and sectoral sections of the HRP and provides links to further guidance. Also, the GNC-CT are currently in the process of finalising a nutrition HRP quality assurance checklist. And this tool can be used while drafting or reviewing the HRP to ensure that nutrition is adequately addressed in all sections of the HRP. So the GNC will circulate this tool shortly. So coming to the cluster sector response plans. So this forms part 3 of the HRP and aligns with step 7 and 8 of the HPC process. So the cluster sector response plans detail how the nutrition cluster will contribute towards the HRP. The cluster plans are either developed with the SAG, endorsed by partners, or developed directly with partners. So that really does depend on the country. So this slide illustrates the general layout of the nutrition cluster response plans. The layout is similar to that of the 2020 HRP cluster plans with no significant changes. At the top of the nutrition cluster response plan, we are to insert the data on the PIN, the people targeted, the financial requirements, and also just to insert a small infographic of the targeting versus PIN map. There are also 4 main subsections. So these include the objectives, target, response priorities, response strategies, cost of response, and monitoring. Usually the cluster plans are around 1 to 2 pages, so it is quite important to keep the plans as concise as possible, as the word or page limit will likely not be on our side. So for the objectives, the nutrition cluster is to develop and present sectoral objectives that are based on the findings of the sectoral and intersectoral needs. And discussed earlier in the presentation, and link this with the specific and strategic objectives. It's important to ensure that the sectoral objectives are consistent with the targeted population groups, the geographic locations, the cross-cutting issues, and intended achievements. It is also important to highlight here the intersectoral collaboration with other sectors. Also, it's important to reach out to the other clusters to ensure that nutrition is adequately addressed within their respective response plans as well. So under the response subsection, here we are required to provide key information such as the number of people targeted against the pins, the targeted subgroups, so disaggregated by sex, age, and disability where possible, based on geographic prioritization. We are also required to provide information on response modalities, again linking with the needs of the population, and information on service delivery and whether cash and vouchers will be used. This plan is to reflect a full package of nutrition interventions where possible. In terms of guidance, the GNC HRP tips document is particularly useful to identify nutrition specific response modalities. It can also support you and other clusters with identifying nutrition sensitive interventions in their respective cluster plans. Also, when considering the response modalities, it is important to systematically consider the possibility of using service delivery in-kind cash and voucher modalities in a complementary way for both multi-sector or sector-specific programming. So the GNC has recently launched a guidance note on the use of cash and voucher assistance for nutrition outcomes in emergencies. This document provides evidence and guidance for the consideration or use of cash and vouchers to better address the nutrition needs of vulnerable populations. So both the guidance document and a webinar on this guidance document are available on the GNC website. We also just want to quickly bring your attention to the Humanitarian Development Nexus. So the HDN is to be considered for both the intersectoral and sectoral plans for the HRP. As part of the Grand Bargain and New Ways of Working framework, the GNC is recommending an integrated model of programming and capacity strengthening with government and civil society structures to bolster the HDN. So cluster and sector plans ideally should consider the localization and early recovery strategies that build national capacity to deliver a quality nutrition response, strengthen local response systems, and engage with local actors to build resilience. So for the development of sector plans, coordination teams are encouraging to engage with SUN colleagues at a country level to identify possible entry points that may not have already been considered, particularly around the recovery, transition, and localized strategies. So the next slide is looking at COVID-19. So as touched upon by Uta, unlike other years, this year we will need to consider the impact of COVID and address accordingly, both in the intersectoral and the cluster response plans. For those that may not be aware, the GHRP will not continue into 2021, and COVID-19 is to be considered together with other shocks or stresses affecting the population, and cluster sector response plans to be adapted as needed. I'm sorry, Uta, did you want to say something there?
I think you pretty much covered it all. GHRP will not continue, and COVID-19 will be analyzed in the HNO amongst a number of other factors, and will be addressed not by separate strategic objectives or by but it will be a part of could be part of a specific objective. Over.
Thank you, Uta. We do recognise that this is going to be the first time that country teams will be addressing COVID-19 into their HRPs, but there is a lot of guidance available that can support with the consideration of COVID. So for example, we have the COVID-19 and Nutrition Technical Working Group TOR template. We have the IYCF in the context of COVID-19, the management of child wasting in the context of COVID-19, maternal diets and nutrition services, the nutrition information management, surveillance and monitoring, the nutrition sectoral and cluster coordination guidance, and also the template for joint statements on IYCF. So these are all specific to the context of COVID-19. So there is quite a lot of guidance there available. If you do feel as though there is a gap in the available guidance, please feel welcome to reach out or to refer to the toolkit, which is available online. So I'll now hand over to Victoria, who will speak through the next 2 slides on the targeting and the monitoring. Over to you, Victoria. Thank you.
Thank you. Hi, colleagues. So right now we're going to zoom in a bit further on how to estimate the number of people targeted. So as discussed, clusters and sectors are required to provide the number of people targeted for each specific nutrition service. So just as we've been doing for the HNO, where we've identified the number of people in need per nutritional need, we now have to identify, based on the needs, what would be the most appropriate, relevant, and feasible targets for our response plans. The number of people targeted for a specific nutrition intervention or program, which humanitarian actors within the nutrition cluster aim or plan to assist. So this is just the definition of what targeted means, because evidently targeted can range in terms of our interpretation. So we're really looking at the selection and identification of people who will be assisted as a part of the response. So since we've already identified the population groups, the humanitarian consequences, and the geographic areas to be prioritized, this is actually a subset of our PIN, so the subset of the people in need, which is being typically smaller, as it is rare that international humanitarian actors can meet all the needs given available resources and, above all, access constraints. So this calculation, once again, should be disaggregated by sex, age, and disability, and done within the nutrition cluster or sector. The process of targeting is based on the assessment and analysis of needs and capacities of the population in need, as well as defining the eligibility criteria and what are the eligible beneficiaries based on the outputs of the HNO and the response analysis. To complete this process, you'll have to agree on the coverage for each type of nutrition service that you are planning to do. These targets will be reflected in the cluster response plan and will contribute overall towards the overall number of people targeted, which will be presented in the intersectoral sections of the HRP. So once again, we're bringing in the intersectoral lens here as well. It is recommended to estimate a humanitarian needs-based target, striving towards 100%, while taking into consideration accessibility and potential constraints. It is important to note that operational capacity and funding trends for a given humanitarian situation should not be considered when determining the target. So it's really looking at accessibility and potential constraints that may affect that overall percentage of people targeted. When determining targets, we also need to consider the sphere standards. So right now for acute malnutrition programs, as many of you are already aware of, we should aim for at least 50% in rural areas, 70% in urban areas, and 90% in camp settings. So the main guidance to support you with estimating the number of people targeted is the nutrition caseload calculator. So on the bottom left or right of your screen. And this tool, as you could see with the nutrition humanitarian needs analysis guidance, is very similar. So there's a lot of similarities that can be taken when estimating the number of targets. So our caseload, remember, is our number of people in need, or PIN, and also provides calculation tools for the supplies. So based on this, evidently everything is on the GNC website, but it's also important to always keep in mind, as we've been doing for the PIN calculation, how to avoid double counting of population groups, particularly if the same population group is participating in different activities. So this summarizes a bit more that kind of step 7 that Uta mentioned previously. And now we're going to be looking at, in terms of monitoring, what are those kind of key indicators at outcome level to keep in mind. In terms of our monitoring plans, once we have our targets, we also need to identify which will be the indicators to be selected to monitor our response plan. So there's table 1 of the Nutrition Humanitarian Needs Analysis Guidance here on the, back end side, right or left, I apologize, I'm not exactly sure. I'd say left side for everyone looking. That details those, remember that the list of those core indicators that are being suggested this year in terms of the situation analysis. So these could be potential ones that can also be included in the monitoring plans, but this also is not comprehensive, as we also have an extensive indicator registry. So it's also available on the Nutrition Humanitarian Needs Analysis calculation tool that's being piloted. So it's in that second tab, if you can see on the screen. And so it really provides the key resources to develop these monitoring plans. And the monitoring of indicators, once again, will feed into our nutrition assessment plans that are done on an annual basis. Once again, number to avoid double counting, that's quite key. We always want to keep that in mind when designing your monitoring plans. And once again, to guide clusters with monitoring and evaluating its performance against the HRP, if we just click one more, we also have another monitoring and evaluation framework template that can be found online at the GNC website. And you can see here, there's a short 10-minute tutorial that explains the process and how you could develop this framework within the information management checklist. So in summary, we have a number of tools here that can support you when developing the monitoring plan to evaluate the performance, monitor and evaluate the performance against the HRP, and should ideally be developed and agreed upon by all cluster partners that have been involved in the HNO and HRP development processes. Although GNC has this template that is readily available, it is important to note that OCHA also has a template for all clusters to complete that is often tailored at country context. Therefore, we recommend you to first check with OCHA at country level if there is a template that has been developed, and if not, please use the template that we've just mentioned here. Usually there's no big differences between the GNC and OCHA templates, as they're based on the same master template at global level. And also, just as a final note, in some contexts there may be no online project system or HPC project module, and in this case the nutrition cluster coordination team will need to consider setting up a means to consolidate the information regarding partners and projects. More information on this can be found on the Nutrition Cluster Coordinator checklist on our GNC website. Back over to you, Bryony.
Thank you, Victoria. So we're going to now discuss the costing of the HRP. And while I speak through the various options for the costing, we're going to launch another poll. So I'm just going to launch that now. So I'll just leave the poll open for 2 minutes. And I just invite everybody to participate in this poll so that we can see what type of costing is being used in your respective setting. So as mentioned in the previous slides, the cluster collective response plan is to be costed, and there are 2 or even 3 ways in which we can do this. So this can be either activity or project based. The method usually depends on the country, but it really does depend on the country context. So when we speak of the activity-based costing, so standard costs for each activity, so for example, SAM treatment, need to be developed within the cluster. So standard costs can be solicited by certain key actors. For example, those involved in SAM treatment. These costs will need to be agreed on by all and harmonized. So activity-based costing is advantageous in that it provides an estimate of the cost for the total needs rather than the cost of what the partners can deliver. However, it is rather complex and time-consuming. To do the project-based costing, projects are uploaded into the HPC projects module. So this was formerly OPS. To compile the cost for each project involved in the nutrition response. So project-based costing also helps to map each partner's planned financial contribution to the response. For some nutrition clusters, it may even be possible to do both types of costing. So that's when we have option 3 of the combined. So this conducts an activity-based costing exercise while still requiring partners to submit project sheets to track partner contributions. So I see that we have 17 people that have now completed the poll, 18 people. I'll just leave it open for another minute to see if we have others that would like to complete the poll. But interestingly, we see that it's almost equal in terms of the number of countries that are doing the activity-based costing and those that are doing the project-based costing. I'll just leave it open for another minute there. So when the clusters are working on the projects, OCHA is usually working on drafting the HRP, and on submission of the cluster projects, the overall response will be calculated and then endorsed by the HCT and finalized. So just looking again at the poll, we just have a few more people to complete, but maybe we'll just close it at 3.5 minutes. Okay, so interestingly, it is almost 50-50. So sharing the results now, option 1, activity-based costing, does appear to be the most popular, but very close with the project-based costing. And then we have the combined at option, which is at 24%. Okay, so I'll just stop sharing that one. Share results, whoops. And just as before, you just need to close the little box which is open on your screen to follow the presentation. So just to flag, while it won't be available for the 2021 HPC process, OCHA is currently working on costing guidance, which will likely be available to support the HRP development from next year. So this will hopefully create a more streamlined approach to HRP costing. So we have now come to the project development and costing. So this is the last step of the HRP process. And this corresponds with step 8 of the overall HPC process. So this is the formulation of projects and activities and estimation of the costs of the response plan. So as we know, partners are responsible for developing costed projects that will ultimately support the nutrition cluster response plan. And to aid this process, nutrition cluster coordination teams are to share the cluster response plans with partners and provide them with adequate guidance so that quality projects are developed. So this is just an example from previous years of guidance that has been shared. So you may wish to organise a project development workshop to discuss the project template, or to discuss who is doing what and where, and to provide guidance on the costing. You may also wish to share guidance on the vetting criteria for the projects. In some countries, OCHA will develop this guidance, but not always. It is also important to provide constant guidance to partners throughout this process, as it may be a new process for some members. And cluster coordinators may also wish to provide support with the uploading of the projects to ensure project submission by the deadline. For the vetting, this is to be organised at a sector or intersectoral level and at sub-national level where applicable. The vetting of projects is to ensure the projects contribute towards the cluster response plan and the strategic and specific objectives. So this brings us to the end of that section on how to address nutrition within the HRP and the sector plans. So we'll just now open up for questions, and then we'll move on to the key considerations for the HRP and the sector plans.
Just to flag that we have got a number of questions in the chat, starting with Abigail, relating to the intersectoral monitoring initiatives. Abigail, could you say which section you were referring to in your question, because it's not completely clear to us?
Yeah, sure. I actually wrote that when the presentation was being made on the sector response plan. I noticed that the examples that were given there were specifically nutrition specific monitoring initiatives. So I was wondering whether we could also include the intersectoral monitoring initiatives under that section. Over.
Thank you, Abigail. So yes, the slide that I presented, that was specific to the sector plans, but yes, thank you for flagging. We can also include the intersectoral examples there as well, and apologies, that's an oversight. I should have included a few intersectoral examples there. And also we can contribute towards the monitoring section of the HRP as well. So not just within the sectoral plans, but the intersectoral plans for the monitoring. And we can also work with our other sector or cluster partners to ensure that nutrition is integrated in their monitoring plans as well. Victoria, would you like to add to that?
Nothing further beyond, when we look at our annual assessment plans, that there will also be intersectoral initiatives that may be collecting a number of your indicators that you've selected. So to be aware that that would also be included in terms of the partners' assessments that will be tracked at country level. Over.
And following up on that, there is a question from Tariq, and maybe this is for Ahmed. If the country information profile does not reflect disability among children 6 to 59 months, then should we use global cutoffs or country available data?
Angelina, since we are a little bit behind the schedule, I see a couple of questions on disability. Maybe Ahmed could address it during
Okay.
the presentation.
Shall we save those for later?
Yeah.
Great. So I think that brings us to the end of that section. I'll now hand over to Masumi, who will speak us through the key considerations. This will address some of the questions that have been raised, as we'll be discussing in more detail AAP, disability, as well as gender and GBV. So over to you, Masumi. Thank you.
Thank you very much, Brioni. I think I will hand over later to Ahmed for disability-specific questions. But so for GBB disability, how do we integrate? So cluster objective, we can integrate to emphasize really safety, access, inclusiveness in the objective. PIN already taught. Also actions that we really can make sure that any of our nutrition or activities are not making harms, which include like protection from sexual exploitation and abuse. And also making sure, for example, persons with disability can access to the services. And the funding, we have this, just I think Brioni just mentioned about our project vetting criteria. That's also a very good opportunity to integrate GBV risk mitigation and disability and AAP. So that's all these projects that has a good consideration of GBV risk, disability, AAP can be prioritized. And then also monitoring that making sure that there is appropriate indicators to measure the progress and then the impact of our integration. And so for we are also proposing twin track approach. One is like mainstreaming, for example, making sure all nutrition services are available and accessible for everyone, whether for children with disability or non-disabilities, or certain groups of our population who are unlikely to access to services. While targeting is, for example, our services specifically for children with disability. I see there were some questions on this too. So for next, please. And for disabilities, I know there was specific questions, so but I will just go through this quickly, and I will hand over to Ahmed before, after I finish the GBB one. So make sure for the participation that you will consult with the person with disabilities and their organizations of the disabilities. And then the feedback mechanism are accessible for the persons with disabilities. Again, as I mentioned before, there is targeted activities and then also the mainstreamed activity. So at the very minimum, to make sure that our persons with disability can access to services. And also for nutrition, it's really the caregivers who brings for example, children under 5. So really important to consider how nutrition services is accessible for children of maybe mother with disability who may not be able to access to nutrition services without specific support. And so also making sure there's some capacity building of the local organization and national organization for good nutrition practices of persons with disabilities, and for monitoring to make sure identify and develop disability specific indicators and also our mainstreamed indicators. So for that you can use sex, age, disability disaggregated data so that you can really check whether, for example, children with disabilities or pregnant and lactating women with disability can access. But again, as I mentioned, our nutrition caregivers who bring children are very, very also important actually people to monitor. And costing, same, making sure for disability, both mainstreamed activities and targeted activities are budgeted and included into the project vetting sheet. Next, please. So for GBV, so GBB has been doing our HRP analysis for 2019 and 2020. Unfortunately, only 4 countries included HRP, and the other clusters has been including 10, 12. So it's pretty low. So how do we do that? If HNO has some GBB risks analysis related to nutrition identified, next please, you can include at least one response strategies to address the barriers or address the risks. But also you can include standard GBB risk mitigation response under indicators. I will show you the standard activities and indicators later. Next, please. So this is just example for some of the barriers that I know it's actually happening. For example, some women cannot go to nutrition services because their husbands don't approve, because the reason could be very different, but in this case, because husbands don't understand the importance of nutrition services. And many countries that women cannot bring their children or herself to the services if husband doesn't allow it, or if they go to nutrition services, they might face the gender-based violences at home. Next, please. So for this, in these cases, for example, you can do you can conduct specific nutrition outreach or nutrition education targeting to the men. So activity itself doesn't look like GBB or doesn't say anything GBB, but by doing this activity, you are addressing these barriers, these key barriers that women have from accessing nutrition services, which is husband understanding. So when you don't have data related to gender-based violence risks and barriers to the nutrition services, you could at least include one or two standard gender-based violence risk mitigation response and indicators. And you can address the data gap by conducting safety audit or include a question into some of the regular nutrition monitoring and assessment. Next, please. So for standard risk mitigation measures, it could be like training of nutrition frontline workers on GBB referrals and disclosures, because vulnerable women access to nutrition services as a pregnant and lactating woman or mother who bring their children to the nutrition services. So chances are very high for nutrition frontline worker to receive GBB referrals. So it's very, very important for them to know how to disclose, how to respond to this kind of disclosures. And safety audit, either it's multi-sectoral or nutrition, that you can do these safety audit. So example of indicators are like number of sites conducted a safety audit and percentage of nutrition staff. But I mean, we can also look at this during the breakout room. So that's all for the GBB. Maybe for AAP, so again, AAP really making sure, the important part is that you make sure that all these, response strategies are made in consultation with the people, and all the nutrition services, there is a way that affected population can provide the feedback. And then in the compliant feedback mechanism, it's not only that are available for like everyone in general, but it should be available for example, persons with disabilities or maybe mother who has a lot of children with disability and has less time to access to it. So it's just important to look at the different barriers that different affected population has to the feedback mechanism. And there is a tools in nutrition. So I will hand it back to Antene. But Antene, maybe would you like to Ahmed to respond to some of the disability related question here?
We are a little bit behind the schedule. Maybe we could go to the breakaway exercise and then come back, and we will then start to take Q&A.
Okay.
Yeah. So are we ready for the breakaway?
Sure. Would you like me to speak through it, Antene, or would you like?
Yes, please. Go ahead, please.
Okay. So we're now going to do a short exercise. So this will take approximately 10 minutes, but we'll try to make it a bit shorter. Just
yeah, probably I think 5 minutes, given that we're a bit late.
Sure. So we'll break out into 3 rooms, and we're going to discuss the 3 cross-cutting issues that have just been raised. So that's AAP, disability, and GBV. And everyone is just going to be randomly allocated to a room. I will share a link in the chat box. I just need to close the screen. And this link will be to a Google document that will list a few examples of activities against each of these key considerations that can potentially be included in your cluster plans. So the purpose of this exercise is to discuss these proposed activities in terms of their feasibility and potentially add additional activities to this list as well. So I'll just now create the breakout rooms with the time limit of 5 minutes. We will then reconvene in this main forum and I'll share the link to the Google Doc in the chat box. So I'll just do that now. Oops. Sorry, it doesn't appear to be allowing me to create the breakout rooms. So I might just need to close my screen. Apologies. Okay.
Okay.
Okay, so I think that everyone has now come back to the main room. So over the next few minutes, we're just going to ask each of the rapporteurs for each of the groups to report back to all of those that have joined on the call to speak about the feasibility of the proposed activities as well as additional activities that they may have identified. So over to you, Antene. Thank you.
Thank you, Bruni. We have 3 activities on AP proposed to be appropriate and feasible at the country level. Out of this quest, the 3 suggested actions, 2 were supported and 1 was suggested to be modified. The first activity, which is about putting a display on the health at the health facilities, which shows the services provided at the the nutrition facility. So the recommendation is to rather have sessions, sensitization, community mobilization, and awareness session on the services provided, rather than posting something which is difficult to be understood by illiterate individuals. So that's one suggestion. So yeah, so the preferences are clearly known. Activity 2 and 3 are more preferred. Thanks.
Thank you, Antene. So over to you, Ahmed.
Thank you. We have also a 3 activity. Unfortunately, we was unable to cover all the activity in the discussion due to the time. However, we have 2 activities that is focusing on disability, which is targeting activity. We're starting with the training, and the highlight was that the activity is possible, but the idea here that we need a training program or training curriculum and material to ensure that we are capable, so the technical support to develop such a training for focusing on frontline worker in nutrition practice for persons with disability. And also we was discussing to which extent we can deliver this training as a standalone or as included in the overall training for the frontline workers. And also the timeline that we should ensure that yes, we have maybe a training program in the beginning of the year or in specific time on the year, but sometime we need to, the service itself is continuous. So whenever we need such a training, we need to involve it. The second one was more mainstreamed activity about how to strengthen inclusive life-saving prevention nutrition services. And we was discussing the indicator and there was a suggestion to modify the age for the indicator to be more inclusive, but also it was possible that we have such an indicator, which is the number of boys and girls receiving preventive service. We should ensure that we are segregating it by disability and age and sex to ensure that we have an inclusive nutrition services. Another indicator was about the pregnant and lactating women and girls, specifically if they have some sort of disability. The last, we have an suggestion added on activity about the coordination with our cluster for integrated services, which is a very strong activity. I think that it's, that the group have suggested in written, which will help to ensure that disability is inclusive. And the last one we didn't have time to discuss, which about the accessibility of distribution point and market and nutrition services for a person with disability. Thank you.
Thank you, Ahmed. And over to you, Masumi.
Thank you. Well, we had for GBB risk mitigation, we have 3 activity. One is training of frontline worker on GBB referrals and PSC, and then the second is the safety audit of nutrition, or specific or multi-sectoral. And third one is, for example, integrated GBB messages into nutrition outreach and so on. And I think the participants think that all are kind of normal, all are kind of acceptable. And then the very encouraging words and training should be just standard. And then nutrition actors should do training plus. So training of GBB referrals should be kind of standard, but making sure, for example, our safety audit happens, and then also integration of GBB messages happening. And then some countries already shared that they have been discussing with protections, and also they've been already have this kind of activities like our integrated our GBB message into nutrition. So I think we are on a good way. And then one request is just discussions already happening. So they want to have these indicators and activities like today after maybe this meeting. Thank you.
So thank you everyone for participating in that exercise. Because of time, what we will do is we will clean the document up a little bit, to reformat it and share it with everyone so that you can use this as a tool to support with your nutrition cluster or sector plans. So I'll now hand over to Antenna, who's going to speak about the roles and responsibilities and the support from the GNC through the HRP process. Thank you, and over to you, Antenna.
Thanks, Brioni. Since we really run out of time, and I would suggest if we could address some of the questions asked, specifically the questions raised on cross-cutting issues. I think there were a couple of questions on disability. It would be good if Ahmed could address those questions, and at the end I will take maybe a couple of minutes to end this session.
Of course.
You see the questions, right?
Yes, it's mostly about the calculating of PIN number. I think that it's one of the issue about disability and inclusion, and also about the data itself and the availability of data. I think that it's very important to differentiate between things, between calculating of number of persons ability in the assessment, which is done usually in HNO, calculating person in needs figure, and in this case, we usually advise that we should have, if we will have a primary data collection, so that means that the team will collect data, primary data. They should include Washington Group question in their data collecting tool, and in this case, they will be able to having an accurate person of person with disability within the country or the covering area. However, sometimes we don't have this luxury. Sometimes we don't have the primary data collection, so we are using secondary data collection. Yes, all the suggested topic like national system, other organizations that have been collecting data about disability could be good resources, but also we know that most of the time these data are not reliable. Either it's underrepresenting or underestimating number of persons with disability. In this case, we are allowed to use the international estimation of a number of disability, persons with disability, which is 15% by WHO and 10% of children. So if you are calculating number of children with disability, it will be 10%. And the global estimation for persons with disability is 15%. However, you should consider that this number is calculating globally. So most of the time in our humanitarian setting, this number is not is much higher than that. So when you do this kind of estimation, you should consider all the other factors. You should consider also to which extent the sector that you have more or less number of persons with disability. So it should be calculated global estimation based on the discussion with of course, the focal group and focal person. However, when we are calculating number of persons with disability have been reached by our service, which is usually happening on monitoring of our response, we should consider a completely different way. Whenever we will have a system service delivery, or we have a nutrition information system, you should include a disability Washington Group short set of disability question with inside this registration system or registration of beneficiaries or monitoring tools to ensure that you capture how many persons with disability you are able to reach during your service provision or during registration of beneficiaries during our work. However, if we will not be able to do that, which is very rare in case of nutrition, maybe in other cases like WASH and other services, it's acceptable, but in nutrition, usually we have a clear information system that covering the beneficiaries' data. And in this case, we should have a more accurate data. However, in this case, we should only assume that 15%, the global version assumption, are reaching to our service if our service is fully inclusion. So if you are designing a service that is fully inclusive for everyone, that can be reached through information, through physical distance, through ability to reach to the, for example, nutrition distribution focal point, all this, it's okay to assume that all the persons with disability in the area have reached it. However, if you don't have a completely accessible services, you don't assume that all that person with disability will be able to reach to your services. I'm not sure if this covering all the question.
I think, I hope it addressed most of the questions. We will have an opportunity also to compile all these questions in a tip sheet. So if anything is not answered, we will include the response in that tip sheet, which we'll be sharing after this webinar. Thanks, Ahmed. Shall we move to the next slide, Brioni, if we can move? Yeah, thank you. So there are other questions posted in the chat box. Apologies, we couldn't really respond these questions now because of time. We will definitely compile these questions, and we are also planning to to have a tip sheet which will have frequently asked questions and response to these major questions. We will include the questions you posted in that document. We will also be sharing a checklist for you to help you in the HRP process. Here, I wanted to really emphasize on two important points. One, the fact that the HRP process or the HPC process in general should be done in acceptable way that ensures that there is inclusiveness and consultation among the partners. So we mentioned this in the HNO process. It is also important to remind ourselves that the process should always be inclusive. It shouldn't be something that should be done by maybe experienced experts within the coordination team or a couple of very active partners, or maybe some very strong international NGOs, UN agencies. It should instead be inclusive of all the partners. So it should be consensus-based, and it should be also a consultative process throughout. So we would like the decision-making at every step of the process of HRP to be consulted with partners, and it is also backed with evidence and data. So please keep in mind the process is important as the outcome or the product. The second aspect, which I would like really to remind all of us, is of course, by the end of all this process, we would like to have a very strong and very dependable document on the humanitarian response plan, on the nutrition, as well as the rest of other clusters. That should meet acceptable quality standard. And as you may be aware of, OCHA globally reviews the HRPs together with other clusters and other donors. There is a steering group which looks at the quality of HRPs. And there are checklists, generic checklists, and we, based on those generic checklists, we have developed nutrition-specific checklists to look at the quality of the HRP and HNO. So we would like all the countries to meet that standard because, as I said, it is a document which guides the response, and it is also an advocacy document for resource mobilization. So it is very important that it is done rigorously, and it reflects the reality on the ground. It captures activities that are relevant and appropriate and feasible, that takes into account the capacity of partners. Also, in cases where government is a key partner, it should also demonstrate that there is a complementarity with the work, which is the response which is done by the government. So the outcome should be meeting the highest possible standard. To ensure that, we will be sharing, as mentioned earlier by Brioni, we will be sharing a checklist, and we will also be at the same time supporting you during the process, as we have done in the HNO. We will continue to support you in the HRP process as well. So just as a reminder, the process should be inclusive and consultative, and the product should meet acceptable quality, which is recognized globally. So with that, I will briefly talk about the next steps. As usual, GNC will be supporting you on need-based basis through one-on-one calls. So feel free, as usual, to reach out to us. We will provide the usual support through help desks. And also, in the drafting process, as you have been doing during the HNO process, we would like you to share the HRP draft document so that our team can review it and provide you timely feedback. If there is need for having a dedicated call, we are happy to organize that. In terms of support, Brioni will be leading for English-speaking countries, and Angeline will be a focal person for French speaking countries, and where we may have also Spanish speaking countries. I'm not so sure, but I don't think Angeline will do that, but Victoria will support the Spanish speaking countries. Probably we may not have one or two. We may have maybe one or two countries Spanish speaking. So additional resources are available at the GNC website, and we will be sharing with you also the resources that are available at the OCHA site. So make use of those resources from the website, and also please, as usual, reach out to us. So with that, I think we will have to conclude today's session, and I would like to thank everyone. Especially I would like to thank Uta from OCHA, and our colleague Masumi and Ahmed from UNICEF EMOPS Geneva for their input throughout this process, and also for joining this webinar. And of course, I would like to thank our colleagues Brioni for leading this webinar, Angeline and Victoria also providing their valuable input and for joining us today. So I thank you, colleagues, for taking your time. As always, we are available. Please reach out to us. And unless there is any last point, I think we have to end today's session. Okay, so it seems there is no further point to make. So thank you so much. Have a good rest of the day. We will send you the presentation slides, the webinar record, and the relevant resources for the HRP. Thank you so much.